Hello and welcome to today's webinar produced by the Public Health Network Cymru. I'm one of the moderators for this session, which is about to start shortly. Before I hand over to the facilitator, I'll run through a couple of things to make sure you get the very best from this webinar. Firstly, subtitles are available in English and Welsh and are accessible by clicking the three dots on your screen and selecting the icon, which is a box with two letter C's inside. These are automatically generated and not produced by ourselves, so apologies for any errors or inconsistencies. You'll notice that your microphones are muted and you have no video enabled for this session. This is so that there are no unnecessary distractions and all focus can be on the presenters. However, you will be able to ask questions throughout the session by using the Q&A box. For most people, this is accessed at the top right of your screen and is a square speech bubble with a question mark in the centre. It's worth opening it now so that you have it visible during the session. Please pop any questions you may have for the presenters into the box, and if possible, indicate which presenter your question is for. Questions will be put live to the presenters at the end, so stick around for that. Should there be a lot of questions and we run out of time, we will follow up with the presenters and produce their responses in a document, and this will be emailed to all registered attendees when it's completed. Could I ask that you do not record, photograph or screenshot any of this event? Should you require copies of slides, please let us know via the Q&A, and where possible we'll forward these on to you. The event is being recorded and the recording will also be available on the PHNC website in a week or so. Please send your email through the Q&A box if you require a certificate of attendance to be emailed to you, and we'll take care of that. In order that you're notified of upcoming events and so you can access a recording of this event, please do consider becoming a member of the Public Health Network Cymru. We'll share a link to our registration page during the event, but you can also access this via our website. Finally, your opinions really do matter a lot to us and they do help shape and inform our work, including what we bring to you in our webinar series and our e-bulletins. So please complete the very short survey at the end of the session. We really do appreciate your feedback and are very grateful for your time. Also, please feel free to leave feedback for the team and presenters during the event in the Q&A. And without further ado, I'm going to hand you over to your facilitator for today's session.
Hello everyone, good afternoon, Prynhawn Dda, and welcome to this webinar, which is the fifth in the Public Health Network Cymru series. Today's topic is the Welsh Government response on health inequalities due to COVID-19 in BAME communities. I'm your facilitator today. My name is Shamala Govindasamy and I work in Public Health Wales. I'm the Programme Manager for the National Safeguarding Team. I'm also the co-chair of the BAME Staff Network at Public Health Wales. Today's topic has resonated with staff in the BAME network, indeed across the organisation and beyond, particularly as a resulting long-standing health inequalities may not have been revealed without the context of the current pandemic, and they're also relevant to BAME people beyond COVID mortalities. Our speaker today is Dr Heather Payne. She's a Senior Professional Advisor in Welsh Government. In case you haven't come across Heather's work, I'll give you very much a condensed biography. Heather completed medical training to practice as a consultant paediatrician. She went on to take various academic roles relating to curriculum development, safeguarding, looked after children and child death monitoring, as well as being a paediatrician member of the Family Justice Council. She's also been a senior professional advisor to Welsh Government since 2011, now with a public health focus on quality and safety of women's and children's health and screening. More recently, Heather has been closely involved in the coronavirus response and has co-chaired with Judge Ray Singh the First Minister's Advisory Group on Unequal Health Outcomes in BAME Communities and chaired the Coronavirus Moral and Ethical Advisory Group for Wales. Now I'm just going to reiterate some housekeeping in case you missed it in the beginning before I hand over to our speaker. So Heather's going to speak for about 40 minutes and after that there'll be a question and answer session for about 10 to 15 minutes. Feel free to post any questions using the chat function during the presentation and we'll address them afterwards. There'll also be an evaluation provided as a link in the chat box at the end of the webinar and a reminder sent after the event. Also a reminder that the webinar is recorded and will be available on the Public Health Network Cymru website within a week of the event. So that's all now from me, and I'll pass you over to Heather, who will outline the work of the First Ministry's Advisory Group on Health Inequalities due to COVID-19 in Black, Asian and minority ethnic communities and the Welsh Government response. So over to you, Heather.
Thank you very much, Shamala. It's a great pleasure to be here and to be able to talk about this really important work, which has been the product of engagement with so many members of the Black, Asian and minority ethnic community around Wales. So I'm a mere conduit to pass on some really important messages, but the work has been done at the sharp end very much, so I just want to pay tribute to all the people of who have been in the First Minister's Advisory Group, because the work has been collaborative, collective, and very much theirs. So here we are to talk about COVID-19, like there was anything else to talk about this year, and this really important fact that we have seen a tremendously concerning difference in adverse outcomes for our Black, Asian and minority ethnic communities during this time. And so, I wanted to explain what had been going on around that, and actually put a challenge out to ourselves. So if I can if we can pass on to the next slide, and if I can just throw out a little challenge to you to actually start thinking about what's important to you about this topic. And actually, here we are in November, but let's cast our mind back to when coronavirus was first identified. It's COVID-19 because it was first identified just before the end of last year. But the first time that we started hearing about it was on the 1st of January this year. So it's very much a 2020 thing. And if you cast your mind back to what you were doing on the 1st of January this year, I know exactly what I was doing, because my first little grandbaby was born, my little grandson. And I've had 2 lockdown grandbabies, a little girl with my other daughter born in June. So I've been very emotionally engaged as well as professionally engaged. And I know all of us have been. So please, I want to make sure that we are focusing what we talk about, because there's a very mixed audience today. You all come from different areas and you already have considerable expertise. So what I want to do is find out what's important to you. So put them in the sidebar, and I'll try and make sure that I bring them in, and Shamala will make sure that we discuss them towards the end, but stick them in there. So, what we've been doing, we've been washing our hands, staying socially distant, we've been ventilating, we've been restricting our travel, restricting our day-to-day contacts ever since, much earlier in the year. Certainly, just to cast our minds back, cases in Wuhan were identified in January, and then what was happening was that we started seeing cases. We were aware that it was going to be a problem. 30th of January, the World Health Organization declared it was a public health emergency of international concern. That seems so long ago now. First cases 28th of February in Italy, and we had our first cases in February as well. First UK death on the 5th of March, and the 11th of March, community transmission was confirmed in Wales. So there were cases being diagnosed on the 5th of March in Wales, where there was no history of foreign travel. Wasn't people coming back from North Italy where they'd all caught it in the ski centre. So, it was beginning to be a problem. Next slide, please. And I think the next slide, it completely brings home to us the importance of the visceral and personal importance of what's been happening in this coronavirus epidemic. Those faces are NHS worker deaths from coronavirus. And those were professional people working in the NHS. And, you know, what became apparent very quickly was just look at the faces. There is a huge amount of, there are Black, Asian and minority ethnic faces there looking at us, no longer with us. It was a signal that was coming out quite early on from the data. It was a signal coming out from the American data before us that Black and ethnic minority people were overrepresented in admissions to intensive care and also in deaths. And sure enough, that was what was happening in our country as well. Can we move on to the next slide? Just to remind ourselves about daily new deaths in the United Kingdom. So this, again, is the ONS data of deaths. And you can see that from the beginning, it's starting to rise up in March, and then it's peaking in kind of mid-April, and then going down again. But just to cast our minds back, 12th of March, the risk in this country was raised by the 4 CMOs from moderate to high. We were all panic buying loo roll. The lockdown was for the whole country. The whole of the UK was announced on the 23rd of March. Pubs and restaurants closed that day, and we were all told to stay at home from the 26th of March. On the 25th of March, the first GP and surgeon in the NHS died. 5th of April, Catherine Calderwood resigned as CMO Scotland because of breaking the, making an unnecessary journey. And by the 28th of April, more than 100 key NHS care and transport and other workers had died. So what I want us to just take from this is there's masses of data out there, and I don't want us to get stuck on any one piece of data. I think what's important for the purposes of our conversation today is the 2 golden threads running through this. What do these differences say about our health services for our Black, Asian and minority ethnic communities? Why, is there a health service reason for these inequalities? Or is it a public health reason, the causes of the causes for inequalities? But the other thing, of course, is the well-being of our Black, Asian and minority ethnic staff. So I want you to keep those 2 golden threads in your head as we go through, thinking about this topic. So if we move on to the next slide, please. Colleagues from around Wales, Judge Ray Singh, who is the chair of the Race Council Cymru, and previously a race equality commissioner in Wales, wrote to Mark Drakeford. So did Professor Keshav Singhal, and they wrote expressing concerns that about these racial discrepancies in outcome. And to be fair, Mark Drakeford, our First Minister, Prif Weinidog, he immediately set up in April his First Minister's advisory group on Black, Asian and minority ethnic health disparities. And so the chair was Judge Ray Singh, and I had the privilege of supporting Ray as a co-chair. And that group worked very quickly and very hard and brought in members and representatives of Race Council Cymru East, which is the ethnic minorities and youth support team, which works extremely intensively and hard across Wales to engage with all ethnic minority communities. And of course, we're talking about Black African, Black Caribbean, we're talking about Asian, South Asian, we're talking about Malaysian, Filipina, but also Roma and Gypsy travellers, and also refugees and asylum seekers, all who have a number of different perspectives. There's different ethnic cultures, there's different faith groups, different circumstances. So again, it was a very diverse group. Set up 2 subgroups. The first one under Professor Keshav Singhal as an orthopaedic surgeon, his focus with his experience in Bapio a British Association for Physicians of Indian Origin. He has done a lot of work supporting his Indian origin colleagues, and the risk assessment subgroup was to actually specifically look at the risks to health professionals. So I'll talk a little bit about that in a moment. And then, of course, the other subgroup, which was chaired by Professor Emmanuel Ogbonna, who is a professor of management science in Cardiff University, very expert in kind of systems and management and risk assessment. And he chaired the Socioeconomic Subgroup because I think it was very clear. And of course, Mark Drakeford, a professor of social work and social science before he became first health minister and now first minister, he knows a thing or two. And he said, you know, first up, his words, the many possible reasons for this disproportionality: higher rates of underlying health conditions, pre-existing inequalities, increased exposure as a result of work, and other vulnerabilities. And he said important work to be done to understand how this relates to the apparently higher level of COVID-19 mortality among people from Black, Asian and minority ethnic backgrounds. So, you know, we absolutely had the support of the First Minister of Wales in taking this work forward. If we go on to the next slide, just to kind of show a little bit of data. Again, this the First Minister's Advisory Group was set up. We had our first meeting on the 21st of April, and this data was actually published just towards the. It was actually published on the 21st of April, but we didn't actually have it at the time. But that we were aware that this was coming, and that shows very clearly. Again, registered hospital deaths from COVID-19 in England, because England, with their larger numbers and ONS data collection, they were able to actually identify this data. And because of their, also because of the fact that the epidemic was largely started in the London, the southeast area, again, the areas of people coming in from other countries, Heathrow, Gatwick, and a larger ethnic minority population. This showed up as a signal much quicker there than it could have in Wales, although we were starting to see it in Wales. So these data are basically showing that compared with white populations, when you look across the, when you look at mortality, hospital deaths by ethnic group, then it's very clear that there is a significant difference in rates compared with the white population. So again, evidence of inequality of outcome. We had to do something about that. Going on to the next slide, please. And again, I really need to explain how rapidly data was coming on stream at the time, and how much and how conflicting an awful lot of the data were. Kind of threading through it, I think these are really helpful pieces of information. So the ethnicity data was emerging gradually. As I say, we started our work on the 21st of April, but some of these things weren't published. The analyses, and you know, the gathering, the cleaning of the data, they weren't published until after. So we could see that critically ill coronavirus patients, so in other words, the admissions to intensive care unit was greater in ethnic minorities. Why? You know, our intensive care colleagues were seeing that, but they didn't know why. Again, first principles tells us that it could be due to issues like diabetes, it could be issues like metabolic syndrome and truncal obesity, but we didn't know. So what we were, I think what's important to convey here is the fact of having to make decisions in a situation of considerable lack of information. So uncertainty was a key principle. The graph on the right shows the COVID-19 deaths of frontline healthcare workers. This is just a slightly different way of analysing the data by occupation. So knowing that our workers on the front line were much more exposed because everybody was told to self-isolate, but you couldn't self-isolate if your job is going to a hospital or a place of care and actually looking after somebody. So it was very clear that our frontline healthcare workers were at a greater risk, and that really concerning big difference in the risk of death for our Black, Asian and minority ethnic colleagues, staring in the face. So what were we going to do about it? So if we move on to the next slide, again, Professor Keshav Singh's subgroup, it worked incredibly fast and derived and published by the 25th of May, when you consider, that's just a month after starting work, this Wales Workforce Risk Assessment Tool, and it's available at the link. It's been refined once or twice since it was published. And I will say, again, there was a very diverse group that worked on that. The risk assessment tool was built very much on the fantastic work in Aneurin Bevan Health Board that Dr. Marissa Hamilton Kirkwood, Director of Public Health there, had already led, had already started doing. The advisory group was able to try and pull together as much consensus opinion, again, in the absence of a lot of firm data. Anybody of you who've kept up with medRxiv, the pre-publication kind of data repository, will know that there were kind of thousands of papers going up. By that time, there was something like 6,500 papers on medRxiv. Now there are over 10,000. So papers being published at a rate of knots around coronavirus. The fantastic thing is, of course, the Creative Commons that was going on. People were putting their data out there. Everybody was sharing data in a way not seen for, I think, ever before. So that was a good thing. So the risk assessment subgroup produced this tool. Just a couple of things about the point about it. Because of uncertainty, there was a lot of reliance on the precautionary principle. If we didn't know whether or not something was actually evidence-based in terms of definitely a risk, then the group made a consensus decision about whether or not it should be in there. So this tool helped people to take them through a series of risk factors, and the things that were coming out that were clearly risk factors then as now is that age is a risk factor. The older you are, the more likely you are to be ill or die, sadly, from coronavirus. Male gender, male sex, actually, biological male sex is a risk factor. But also we had this evidence that ethnicity was a risk factor. So it was a simple scoring system, but also things like cardiovascular disease, diabetes, and we also had the shielding data to include in that as well. So that was all included. They got a scoring system, and you can see that what it said was that if you were low risk, then fine, just take the normal PPE precautions. If you were high risk, which is the amber, so we had low, high, and very high. And very high was basically saying, look, stay away from direct contact. And again, not forgetting that PPE was not 100% available, or we didn't know as much about what was effective PPE, about aerosol generating procedures. So for better or worse, that was the scoring system. There were other scoring systems out there, but the beauty of this is that it contained a so what part. So it basically, the NHS in Wales committed itself to saying, if you are a very high scorer on this, you shouldn't be in direct contact with patients because you might get coronavirus, in which case you should be working at home and we will pay you. We could do that in the NHS. And again, that was a government decision in order to support people, which included the support for Black, Asian and minority ethnic people at greater risk. So, that was a key part of it. So that was published on the 25th of May. If we move forward to the next slide, something else quite important happened on the 25th of May as well. Dreadful, awful situation with the death of George Floyd. Again, appeared to be an extrajudicial killing of some sort. But again, we cannot finalise how we think about that in legal terms, but I think we can finalise how we think about that in moral and our gut reaction. That is just something awful that should never have happened. And as you'll see, the protests that happened on the left hand of the screen in America, in Minneapolis, which is where he died. And of course, within a week or so, by the 31st of May, the right hand picture is in Trafalgar Square, and it is the British race equality protests, which also took place in Manchester and Cardiff. And you'll see a lot of people wearing face coverings, face masks at the time as well. So I include that because it absolutely, I don't know, it kind of, I think it just brought it home to everybody that not only was this happening in coronavirus in our health services, but actually this was still happening. This kind of adverse experience for Black, Asian and minority ethnic people was happening in real life under our noses. So that's why it was important. So let's go on to the next slide, because I mentioned the two subgroups. The second subgroup, of course, was the socioeconomic subgroup. Again, looking for the causes of the causes, chaired by Professor Emmanuel Ogbonna, and the link is there in the, you'll have the slides, and so you'll be able to access. Now, this was a terrific piece of work. It was a result of wide engagement, conversations with Race Council Cymru, with East, with kind of local racial equality groups and community groups around Wales. So it was a wide engagement and listening process, and used quantitative as well as qualitative methods to bring messages together. I attended meetings and listened to at least 400 people and synthesized the things that they were saying. And the whole process, some fantastic work with sales, secure anonymized information linkage, bringing together our knowledge and analytical services. So again, it's all in the report. It is a superb report that Professor Emmanuel presided over. It's really worth reading. Just to say that they had a parallel process in England with NHS England, chaired by Professor Kevin Fenton, and actually the crossover between our findings were incredibly similar. I'll just run through the key points. You can read them, but I just want to run through them because those are the things that was the call to action that we all needed. So it was, you know, the data was saying Black, Asian and minority ethnic community members were up to twice as likely to die from coronavirus. So that was just simply a fact. The next question was why? And we started looking for the data. The data is rubbish. You know, we just looked for the data on ethnicity in NHS Wales. It's still only about 75% accurate. So, you know, there are lots of things we can't tell from that. The data in Sale had lots of conflicting ethnicity allocations in it. And, you know, you could say, well, why would, if all you get is discriminated against, if you mark yourself down as a racial minority, an ethnic minority, why would you disclose it? And, you know, I think that's a perfectly important question to answer. So what we were hearing from the report is that there are race inequalities, there is structural and systemic disadvantage in Wales. There were experiences of racism here and now reported to us. I heard them myself. It's no mistake, and I'm afraid it's not acceptable. So again, that was a very, very important. It was very important to actually experience that, I think, and I think it's so important to share that sometimes we think, oh, well, you know, people aren't racist these days, but I'm afraid there are direct experiences of racial discrimination. We'll come on to those. The effectiveness and cultural suitability of the health information and our services, you know, do they actually reach people? We know that we've got social gradients How good are we at actually being responsive to those? Answer, not always very good. There is also income and employment insecurity for people who are in all these different Black and minority ethnic populations. There's housing overcrowding. So again, we're moving away from the health service. We're looking at health outcomes, but we are back into the causes of the causes: finance, housing, financial burden created by migration status, violence against women, children, domestic advice, sexual violence, mental well-being, young people's anxiety around their futures, their representation, and their are they actually seen in our civic and community structures, and are they represented and heard? So that's actually an obligation under our public sector equality duty. So how are we actually managing that, and is it really effective? And it also concluded that we do need to embed anti-oppressive practices across all our public services in Wales. So no big ask there then. It clearly left us with a lot to do. It's published on the 22nd of June, and I think it's a fantastic piece of work. I do recommend you go and have a look at it, and it's supported by lots and lots of data. So let's move on to the next slide and just enlarge on some of those points. We heard about the lived experience of racism in Wales in 2020, and I'm afraid it is with us. There is direct evidence of racist speech and action. It's often not intentional, and again, I think one of the things that we need to do is make sure that we disaggregate what is happening from what we can do about it. There is institutional racism, there's individual racism, and individual racism should be a disciplinary offence, and often is, but it is found to be more subtle than that by people who report that they are experiencing it, and it's seen as microaggressions, just a look. It's known as the look, almost like as kind of double take. And again, I'm not accusing people of being racist, but we all are in some way, and I think just that self-insight is really important to be able to modify our behaviour and actually engage more openly across the piece. Things like work allocation, the availability of PPE and protection. Again, all these things are in the report. Contractual status, there was a lot of casual and bank work. Minority ethnic groups were far overrepresented in pay structures, but also in promotion and appointment procedures and representation. So there were a lot of very related, socioeconomically related issues. Too many to go into now, but there was lots of evidence of it, and there's something that we clearly need to do something about in the health service, but also in public services generally. Just move on to the next slide. Just to, as an example, availability of PPE and face coverings. There were reports of racial inequality in access by frontline workers and people who were on less substantive contracts. So again, they needed to be looked into, and they were passed back to source. But the fact that people are having to say things like that, it's unacceptable that any individual group of workers should be put at increased risk. So again, knowing where the problems were so that we could actually address them. There were one of the things that hampered investigation of these issues was relatively poor quality evidence of both information around supplies of PPE, of clarity of messaging of who should wear it in what context, whether or not it should be reused, because of course back in March, April, if you remember, it was clear that aerosol as well as direct contact was an issue, and an awful lot of these policies were being developed on the hoof. So huge problems. Let's move on to the next slide. One of the important things that I think became apparent was the just the kind of institutional assumptions, and I've put Sir Thomas Picton up here because although he on the left you'll see the Picton Memorial in Carmarthen, because of course Sir Thomas Picton was a Welshman who died at the Battle of Waterloo, but and he has a statue in Cardiff City Hall in the Marble Hall upstairs, but unfortunately on further examination he was clearly a very had a number of unsavoury stories attached with his activities in the West Indies when he was the governor there as part of British Empire. And again, why are we glorifying people who have displayed cruelty and racism? Again, I don't want to get into the argument about the kind of history, but if we are talking about our history as Wales, then Black history is part of that, and we need to get these things in perspective and maybe not glorify some things that we had just swept under the carpet. So again, no time to go in. Somebody's mentioned Colston buildings and statues. Again, it's the kind of reappraisal of our history. In Oxford, you know, they're looking at the Rhodes statue. The Rhodes must fall. So again, we cannot rewrite history, but we can reinterpret history, and we have to do that together. And of course, Dana Legal, who is one of our who's on our group, the First Minister's Advisory Group, has been appointed to a task and finish group to audit public monuments. So again, that work stream is going on, but what we have to do is reflect on what messages we are giving, not just verbally and on the surface, but the subtext as well. Let's move on to the next slide. Again, what we teach our children and how we teach it is tremendously important. And Professor Charlotte Williams is reviewing the Black, Asian and minority ethnic communities contributions, and Cynefin, which of course is a Welsh term which is about the kind of problem solving skill in the new curriculum working group, and bringing in Black history, not just Black History Month. I mean, why not 365 days of the year? We are you know, a mixed community. We have the fortune in Wales having long-standing Somali, Yemeni, seafaring communities in Cardiff and in other parts of Wales. So we should be capitalising on that. And again, looking at the graph on the right, showing differential attainment in schools. This is across the UK. Again, some ethnic groups do far better. You could argue that in the valleys, Four Valleys white boys are the most deprived ethnic group. But the point is we have to be reflexive about this. We have to look for the data and make sure that we deal with it. Moving on to the next slide. Again, local lockdowns were part of what you know, our response to COVID. That's in Caerphilly, of course. That helped to reduce infections, but affect people in lower paid and insecure work. So again, there's a racial and an ethnic divide there. On to the next slide. We have to make sure that we have culturally appropriate communications. On the left, you'll see Matt Hancock as the Health Secretary with a simple, clear message. Stay alert, control the virus, save lives. Nobody was quite sure what alert was, but you know, it was a simple 3-item message. Compare that with the quite kind of martial appearance with flags and our Health Minister, Vaughan Gething, you know, engaging in much more individual conversations and being very, and visible ethnic minority representation in Wales as somebody in a position, a real leader. So, we are very fortunate, and we need to capitalise on that sort of thing. Thinking about effective communications, it's not what you say, it's the way that you say it, and using things like the COM-B process so that we are actually using capability, opportunity, motivation and behaviour as a model which recognises the system that we're all in. So moving on to the next slide. What did we do about these things? The Deputy Minister and Chief Whip, Jane Hutt, who is our ministerial lead for equalities. Again, there's been a really effective attempt at response from the Welsh Government. When I say attempt, I mean it's happened, it just hasn't worked through yet, because so we don't know whether it has been effective, but it's been put in place. So funding, supporting outreach workers. So in other words, rather than sending health workers out there to support Black, Asian and minority ethnic communities, identify people from those communities, bring them in, give them core skills around health, and put them out to work with their communities, pay them properly, and make a coordinated process. So, that's been put in place. And the next slide shows us, if you remember the two threads, the first one, the working with communities, is to address issues in the communities, and the second thread was our workforce. What we have taken on board from work that's happened from the King's Fund, you'll see on the left the link and the reference there, because on the right are the questions of the Workforce Race Equality Standard, which is a metric, a tool that has been in place, in use in NHS England for the past 5 years. The King's Fund report is a report of its evaluation. And so what has happened is that we are now looking at using the Workforce Race Equality Standard here in Wales for our NHS and for any other organisations which are interested in using them. But I think we have to demonstrate first in the NHS that it's doable, that it's valuable, and that we can make progress. It's an important thing to do, in my view. I will warn that the 5-year report from England has shown limited traction of that strategy, but I think we can probably do better than that. Moving on to the next slide. Again, one of the Welsh Government response to Professor Ogbonna's report and to the work of the of Judge Ray Singh's group overall, with Professor Keshav Singh's workforce risk assessment tool, is to actually put this information into the Race Equality Action Plan for Wales, and that is being chaired. The steering group to develop that is being chaired by Professor Emmanuel Ogbonna, who produced the socioeconomic report, and Dame Sian Morgan, our very top civil servant, our Perm Sec. So, and this picture shows the Race Council Cymru Youth Forum with our Minister, Vaughan Gething, Minister for Health and Social Services. And again, looking at all the other factors, not just health services, we're looking at health outcomes, but it's the causes of the causes. So looking at research on overcrowding, multi-generational families, how we've dealt with the homeless during this pandemic, how we've been dealing with refugees. You'll have seen all these things in the news, but again, the whole structural response, not just in health services, across all services, is an important part of the response. So moving on to the next slide, just you'll have these slides. So I've just listed the changes to promote better equality for Black, Asian and minority ethnic communities in Wales. These are all the actions that have already taken place. So the risk assessment tool, test, trace and protect with the outreach workers. Next slide, again, scoping a race disparity unit. So in other words, getting the data so that we are actually ahead of the game and predicting, establishing real contribution to the curriculum, like as I mentioned with Professor Charlotte Williams, and including Health, Education and Improvement Wales, reviewing all our skills and competencies. And on to the third slide, looking at and evaluating the working environment, working with our community organisations, East, EYST out there, working with so many voluntary and third sector organisations. We've got to be listening. When I say we, our systems have got to be listening, and also making sure that our diverse community in Wales is represented in public appointments and boards and everywhere where they bring a perspective. So moving on to just kind of closing up and asking you to bring forward your questions. Most of us like to think of ourselves as not racist. And if we look on the left-hand side, you could say, well, look at that. We've got white earnings in the middle there, and we've got people up, Chinese people, the highest average earnings, then Indian, then multiple ethnic groups, then white British, then Asian, and down to the bottom, you've got Pakistani, Bangladeshi at the bottom of the pile. And so, that's a fact. That's one interpretation. But when we say, well, why is that? Actually, you find that if you are looking at, the length of time people have been here, the reason why they've been in Britain, and whether it's ethnicity or immigration status, there is clear differential there. The question is, how fair is that differential and what should we do about it? We need to be looking at those metrics. But what we also need to say is, what kind of lens are we putting on that? Are we saying that everybody should be paid the same for everything? Well, clearly not, because that would be a very different society from the one we've got. That what we are looking for is getting rid of unfairness and inequality, fair pay for the same work. On the right-hand side, I've just kind of put Lewis Hamilton there as one of our fantastic British. I think his achievements will not be surpassed, frankly. Certainly not in my lifetime. In Formula One motor racing, he has tried to bring Black Lives Matter into Formula One. Not everybody has wanted to take the knee. Again, I make no comment about that, but people are wearing End Racism t-shirts. Looking for different ways of expressing solidarity and support is important. So again, there's plenty to talk about there. Moving on to my last slide, I leave the question for us: what next? How are we going to be anti-oppressive in our behaviour? We've got a very recent report from the King's Fund kind of saying, look, we've got workforce race inequalities and inclusion in the NHS. That gives us clues about what we should do about it. Establishing staff networks, making safe spaces for people to speak up, and enabling staff development and career progression. Paper in the Lancet just in July, moving towards anti-racist praxis in medicine, and in other professional journals. Personally, I think that actually our personal reading is tremendously important, and so I've got my current reading is Strange Fruit by Keenan Malik, Why Both Sides Are Wrong in the Race Debate. But I've also been you could read To Kill a Mockingbird. There are all sorts of things that you might choose, but do read, do commit, and let us answer the questions together. So I'll close there and hand you back.
Hi, thank you, Heather. That was really informative and engaging and evidence-backed as well, particularly good stuff about structural and systemic racism, but also the differential between individual and institutional racism as well. We've had very lively chats, questions coming through. So shall we, I'll pick out a few of them to make sure there's a variety. So one of the first questions we've had come in is, why are ethnic inequalities in health given less credence when compared to the influx of interest and government emphasis on mitigating socioeconomic inequalities. So basically, why so much interest in socioeconomic inequalities as opposed to ethnic inequalities? So over to you.
Yeah, do you know what? I think that's a really important question. I think it's very attitudinally based, and I think we've been colourblind for too long. I think we've assumed that we are not racist, and I think that's always the wrong position to start from. And like any dealing with any area of inequality, you know, we went through this a while back in terms of gender equality, and we ended up with the Athena Swan measures in universities, and those are basically saying you actually have to look around and see what people can do. You shouldn't do business in nightclubs and after hours. You should have core hours so that to allow people to get their kids to school or look after their older people. So again, having the right approach, which makes these things visible, I think is absolutely vital. So yeah, we just need to start thinking in that space so that we can get the right receptors coming. We can use the right receptors to work on the right data effectively.
Okay. All right, thank you. Yes, I think we've got the evidence as well now that we can start having that conversation. There's a question come in focused on vaccines. Are BAME groups seen as a priority for vaccines, or will they be the last in line as they're not able to negotiate their health system?
It's certainly been a risk-based approach, and at the moment, for instance, the people who are clearly in the highest risk groups have been the very elderly, but also people who put themselves in at risk in the line of work. So in other words, the main kind of protection against this virus at the moment is social distancing. It's staying 2 meters away from somebody. But if your work doesn't allow you to do that, then that makes you a priority. So that is very much part of the thinking. But what I will say is that is still kind of being worked out in detail, but it is certainly biggest risk gets top priority, and the prioritization is in order of that. And risk, ethnicity and evidential risk is very much being worked into that prioritization process. So I think the good thing about the bad things that have happened is that there is now there's a subgroup of SAGE, you know, the Scientific Advisory Group for Emergencies, which I'm a member of, not of SAGE, of the subgroup, the ethnicity subgroup. This voice is being heard in the prioritization process. It's still got to be fair within, you know, within the whole picture, because a black or minority ethnic 20-year-old is still at much lower risk than a white 80-year-old. So again, it's the multifaceted nature of risk, but it is fortunately now being taken seriously as in an evidence-based way, as one of the factors that has to be taken into account across the board.
Thank you. Thank you. I expect it'll be a bit like the workforce risk assessment. It's a multi-factor approach. Trying to pick on a slightly different question now. With the research and the report undertaken, someone has asked, do you think it will be repeated, or are the factors looked at now there's widespread community transmission, as early on BAME groups were more likely to be exposed due to their occupation? Do you think it's something that would be undertaken again because it might be different?
Well, I think one thing that is happening now is that all this monitoring is continuing, but also our ethnicity data has had a kick up the backside and is much better than it was. Everybody has been asked to work on it, certainly across NHS Wales. Part of that is actually engaging with populations and saying, is there a reason why you don't want to actually identify your ethnicity? Because the problem that we're dealing with is largely missing data. So, but of course, in order to record your data accurately, there's got to be something in it for you. So, you know, why would people record themselves as any particular ethnic group if they feel that it's never going to give them any advantage and possibly a disadvantage? So, so that conversation is actively going on as part of our process of addressing the border problem.
Right, thank you. Yes, we had a couple of questions coming. We had a couple of questions coming in about how we're going to improve data collection. When you say, as you say, it's a missing. Most people are asking. It's the non-declaration. It's the unknown. I've had a question about, do you think the Black Lives Matter movement and the uprise against racism in 2020 has impacted ethnic minorities' willingness to comply to government regulations in relation to COVID? That's quite a big question.
Yeah, do you know what? It's been a fantastic experience to be a privileged part of the race and ethnicity networks and the mechanisms that we have coming into government, to hear people's stories. And as I mentioned, it's been an incredibly consistent story about, yes, there are problems, yes, there are discriminations, yes, there are microaggressions. And again, I would focus that into saying we know there are problems, but what we have to do is engage with across all communities and enable everybody to have a voice, which is very much what the PermSec, Sian Morgan and Professor Emmanuel Bonner's group is aiming to do. So it's about having that community-based conversation so that we move forward together. It's a huge question, but I think it's the important thing is how we answer it, that we should answer it as part of a diverse Welsh community together.
Right, absolutely. We need to finish in a couple of minutes, so I'll just give you, I think there's one more question about the standard in Wales. I think someone's talking about the race equality workforce standard. Is there some sort of timeline on this? Are we taking this on or not?
Again, that is with our NHS workforce directors and engaging with their own populations. It's certainly something that's been put forward as a candidate because it's off the peg, it's there. There are specific ones for specific areas of work. So that is actually in discussion. So I think if people have strong views, they should make them heard, because I think the more support for it, the better. I think it's absolutely essential to have a metric. It's there, it's off the peg. I think we should be using it. But again, it's for the NHS in Wales to take this forward, because it doesn't give you the answer, it tells you where the problems are, and then you work together on the answers. Okay,
thank you. Just waiting for the camera. Thank you, Heather. That's a good action for us as well. I think I'm very aware that this presentation shouldn't be about what is the Welsh Government doing, that we all have our actions to play there. Before I wrap up, have you got any final comments on how we can sort of keep in touch, or what to watch out for, or any actions for us indeed as individuals and members of organisations?
I think that it's incumbent on all of us to develop our own equality and diversity skills. We have to be reflexive. How are we coming over to other people? We have to be reflective about what is effective, how other people might be thinking and feeling. I think we have to develop appropriate vocabularies and skills in order to be an inclusive and affirming both health service but also population. Don't forget, you know, there's our own colleagues in the health service, and there are the people who we serve out there. So it's a big ask, but but again, solidarity and collaboration and being critical friends to each other, I think, is the most important way forward. Because, you know, as a small nation, as a diverse nation, we can do it in Wales. So I think it's absolutely vital that we, you know, we set out our stall, we work together and deliver.
Okay, thank you, Heather. Really strong messages there, and I hope we can all take those on. We've reached the end of the session. I'd really like to thank Heather for a really informative, engaging session. I learnt a lot, and thank you and your colleagues in Welsh Government for all that you've done, and hopefully all that you will do, because this is ongoing. It's ongoing as well. Okay, for everyone here, just another reminder, there's an evaluation that will come up in the chat. But on behalf of Public Health Network Cymru, I'd like to thank you all for coming and engaging today, and hope to see you again soon. Okay, goodbye.